Okay, great. So our next speaker is going to be Dr. Alejandro Macias. I was saying at the beginning of the session, he is a medical doctor and infectologist from the University of Guanajuato. He is a leader, actually, an academic leader in not only infectology, but also in recent times during the pandemic, also has been a very leading voice about the public health implications of the pandemic. He's also very known for being commissioned as the main person from the health secretary in Mexico during the 2009 influenza pandemic in Mexico. And since then also he has been producing a lot of academic and scientific research in infectious diseases. And like I said, thanks to him, we have been properly informed, I would say, during the pandemic about, you know, precautions and measures and what information is real and what is not. So it's really a pleasure to have someone of this level, and also very proud to be local. I was telling you, he is from here, Guanajuato. And thank you very much, Dr. Alejandro Macias. If you're already online, go ahead. We're going to be listening to your talk virtually, and then he will be coming up shortly.
Good afternoon. Let me share my screen. I hope you can see it now. You can see it now, huh? Okay, thank you to Simba staff, Dr. Herrera Estrella, for this kind invitation for me to talk to you about the epidemiological and clinical aspects of COVID-19. I have no conflicts of interest. Let's remember the variants of virus that are intrinsically linked to their capacity to escape the immunity from one side and to favor transmissibility. In this sense, the severity of disease is not something that, quote unquote, pretend the virus. The severity is just a byproduct. It's an accidental product, but the variants try to get more infectious and to have more escape, which means the virus wants to reinfect those who had already infected before and to infect those that are already vaccinated. So in a given time in the evolution of the pandemic, some variants may have some advantage that we will not have in other times of the pandemic. Fortunately, for COVID-19, this evolution, this accidental evolution, points towards a less virulent variant. We know now that the Omicron variant infects much more, but with much less severity. You can see it here. In this area, you can see how the Omicron in blue does not infect well lung cells, if you compare against the original Wuhan virus and the Delta virus. But they infect, this variant infects very well the upper respiratory tract, as you can see here from bronchus, against the lower capacity of infection for the upper respiratory tract of the original Wuhan and Delta viruses. So it seems that at least for this coronavirus, it's evolving towards becoming a catarrhal, a cold virus. Maybe could in the future get a reverse, but it seems at this point toward becoming part of the repertoire of the catarrhal, of the cold virus that infects us every year. This is the evolution. You had talked about this. I will not elaborate too much in this, but just see how these variants do not like competition. They were, like in 2020, conforming all the local variants. By 2021, these variants of concern because they could transmit much better and they could escape immunity, they were configuring this table in May, and you can see that by then we had in Asia, Delta, in Europe and North America, Alpha, in South America, Gamma, in some areas of the world, Beta, but they do not like competition. Just 3 months later, Delta had already taken over the whole landscape. And the same happened with Omicron. And by now, this is now, Omicron, it's taking the whole landscape. Almost every country with problems now have this Omicron variant, but we have two different Omicrons. The original BA1, as you know, and now the BA2, which is driving the pandemic in China, South Korea, a good part of Europe and Israel, but not in Mexico and in South Africa. And that's a little weird. And I will go back to that a little later. From the beginning, it was clear that the new variants have some escape. I will show you here in blue, the Pfizer. This was one of the first studies in 2021. Check here in Israel against the Alpha variant. The Delta variant was the vaccine of Pfizer, the Pfizer vaccine was much less efficient, but was not less efficient against severe disease and hospitalization. And that's still true for almost any vaccine. Vaccines are not good for you not to get infection. Vaccines are good for you not to get severely sick, to not go to the hospital, to not die from the infection. That's still true. So this immune escape is more against mild disease than against severe disease. So how did we know which were the mechanisms of transmission? When all of this started, you may remember that we were very worried about the contact transmission. Now we know that contact transmission does not play a factor in this pandemic. How did we know? Because of the analysis of outbreaks like this one. This is an outbreak in South Korea when the pandemic started there. This is a 20 stories, 20 floor building. In the 11th floor, they have this call center. You can see in blue all the people that got infected, even not having contact between them. But here, you can see in yellow that people one floor below, in 10th floor, got infected, 3 of them, and 1 person in the 9th floor. So from the analysis of this outbreak and many other outbreaks, it's clear now that this is a disease that you breathe. This is not a disease that gets transmitted via direct or indirect contact. Later on, the investigators in the University of Florida demonstrated that they could isolate the virus from the air, and they could use that virus to infect cells in the laboratory. You could isolate the virus like 5 meters from the patients. So the virus is in the air. And one of the lessons of this pandemic is that the hygiene will have to evolve towards clean air for everyone. I will go back to that a little later. And so we understood the importance of face masks. Now we know that face masks work. They protect your health, your wallet, your economy, and they give you time while vaccines arrive. Unfortunately, in countries like Mexico, Brazil, and the United States, the use of face masks was politicized, and that was a real disgrace because mathematical models show that if you consistently use the face mask, you will drop the transmission in a very efficient way. One more of the clinical aspects that we learned from this pandemic was this very important concept. You do not get infection like the Midas touch. You need to breathe a lot of viruses because this is more like a probabilistic phenomenon. If you wear a mask, you protect others because you expel a lesser amount of viruses. But if you wear a mask, you protect yourself because you will breathe a lesser amount of viruses also. And if you need like 1,000 viruses and you have a face mask that protects you 95%, you will breathe only 50 viruses. And with 100 viruses, you may get infected, but not with 50 viruses. So this is a very important concept, the concept of masking and time. More time, because the masks are not perfect. Viruses go through the face masks, but you prolong the time that you will need eventually to get sick. One more of the concepts that we have to understand is the concept of the risk inside and the risk outside. This is maybe you have seen these readers of CO2, like they are used like proxy for the quality of the air that we are breathing. Normal PPEs, ppms, part per million, is usually like 400. Just see readings in the subway in Mexico City, almost 2,000, and windows closed. This person has got the face mask, but if you keep there like 15, 20 minutes, you may get infected even if you have your personal protection equipment. And this is a reading I did in some intensive care units. Maybe you cannot see it, but this reader is showing like 1,100, almost like in the subway in Mexico City. So you may get sick going in intensive care because you got an accident. You are having a good evolution, but then you acquire influenza or COVID in the hospital, and you may die in the hospital because a problem you got there. So in the future, as hygiene have evolved to drink clean water, we'll have to understand that we will need to breathe clean air. So the personal protection equipment are great, but we will have to favor ventilation in the future, not only the equipment for protection. Maybe it's better, as you can see in this triangle, maybe ventilation is even better than personal protection equipment. I'll give you an anecdotal. I had attended hundreds of patients with COVID in Mexico. And up to now, I have not suffered COVID. But I always take a very good care of ventilation. Ventilation in my office, ventilation in the hospitals I visit. If ventilation is not good, I go in and out soon. I think that ventilation is going to be one of the big lessons of this pandemic. And we used to use a lot of personal protection equipment at the beginning. Gowns, gloves, double gloves, pants, boots, Tyvek suits, whatever. What we really need for diseases that are acquired through ventilation, through breathing, you need a good face mask and maybe ocular protection. And that's it. I still see in some hospitals that they require you to dress like this to check for COVID patients. There's an international claim for we to clean the air. This is a recent paper, a recent article in The Economist. This is a recent declaration currently of the World Health Organization. We need to clean the air. The day before yesterday, the White House asked for cleaning the air of buildings in the United States. I think that we'll have to use more of these readers. I have one in my office. I have one in my pocket when I visit patients in hospitals, because these are good proxy measures of the quality of the air that we are breathing. And it's not only the microbial risk. It's clear that if we are breathing in closed boxes that are our buildings, we are also breathing a lot of volatile components like formaldehyde, benzene, and whatever. The source of that is carpets, the walls, the furniture, even the electronic instruments that we have. So we will have to evolve to have not only clean water, but this protection of aerosols had to become like universal, at least in hospitals. This is a paper I recently wrote for the Spanish edition of the Washington Post, in which I established that clean air should be for everyone. We evolved in small groups historically, but now we gather in crowds, in closed boxes that are our buildings, our houses. But our houses and buildings are making us sick. The architecture must evolve in favor of ventilation. And in hospitals, the airway precautions against aerosols should be universal. In Mexico, we still have COVID hospitals and non-COVID hospitals. That will not be possible in the future. It's not only possible, it's not convenient. We need clean air for everyone. In the epidemiology of the pandemic, we have in the world supposedly about 500 million infections. We know that we have much more than that, very much more than that. We are 7 billion people. It's not possible to have less than, let's say, 4 billion infections. And that's, we have registered about 6 million. We know by the analysis of excessive mortality that deaths are not lesser than maybe 11 million in the world. When all of this ends, maybe 30 million people will have died of this pandemic in the world. Mexico is one of the countries that have been severely affected by this COVID-19. We had originally our waves, local variants, then by the end of 2020 and January, February 21, Alpha, Gamma variants, and then Delta, and then Omicron. And now we are living now the Omicron wave. Are we gonna have an upturn because we are still waiting for this variety of Omicron BA2? We don't really know. It's not happening the world over. Just see what's happening in South Africa. They had a situation that was similar to the one in Mexico. They went through different peaks, different waves, locals, Beta, Delta, Omicron up, Omicron down. And then when they had the substitution of the original Omicron by the BA2, they did not have an upturn. It seems that Omicron BA2 is good to reinfect people that is vaccinated, but it's not very good to infect people that has suffered the infection previously, at least for the Omicron variant. So it seems that the infection of Omicron that's driving now the pandemic in China, South Korea, Israel, and Europe is more against people that is vaccinated but has not suffered the natural infection. And in Mexico and the United States, we have had a lot of natural infection. So we don't know if we will have an upturn of the infection, but it's not necessarily so, as we can see now in South Africa. It's gonna be when this pandemic will be over. Well, in Mexico, at least from what I know, you can see this in this line. Even recently, from 100 people that went to have a PCR done, like 70% was positive in some of these states. Now we are about 20% according to official data. I think that we cannot tell, because in Mexico, I have heard that people is already saying, okay, this is over, well, let's go for the next pandemic. No, we are still in this pandemic, this black line, about 20%. I think that if we don't go below 5%, this is not over yet. And I think we are like maybe 1 or 2 months away from that point. In clinical aspects, I think it's important to remember that at the beginning, we have a high viral response, a high viral phase, and then that viral phase is substituted by the inflammatory phase. At the beginning, you should never use immunosuppressants like steroids, like dexamethasone. And unfortunately, it's almost the rule in many medical consultations in Mexico. Here you can see. And at the beginning, we have a lot of virus and low inflammation. Then a high of inflammation and low virus. Maybe by the 2nd or 3rd week, you can use dexamethasone, steroids, or something to depress immunity, but no before. Unfortunately, as I said, it's being done still now in Mexico. And we'll have a lot of post-acute and chronic patients. The virus is gone, but a lot of patients, maybe 10% of all those that got some mild or severe disease will have some degree of fatigue. We don't know for how long. Some difficulties to breathe, some difficulties to think, the brain fog, thromboembolisms, joint pains, whatever. This is going to be one of the big loads of public health in the next months. This is what we see in clinical, in the clinical side of the patients. First, we had to measure about what's the percentage of lung affected. If, like this patient, this is starting what we, sorry, this is in Spanish, but this is what we call the ground glass. And then we have what is called the tiling. And then later on, we have the consolidation. But if you have more than 50% of the lung affected, you may end up almost by certain requiring some kind of ventilation, of mechanical ventilation, or at least some help for your ventilation. These patients are the ones that eventually end up in intensive care. You certainly have heard of this happy hypoxemia. It is very, very common. Patients do not realize they are severely sick. You can see people that are breathing with a saturation of 70% that are happy checking the screen of their cell phones. We have never seen something like that, because people, when they are breathing like at 80%, they feel they die. And in this infection, we can see people like with saturation of 60%, they are happy talking, they don't realize they are dying, literally. So we have advised to everyone, buy yourself an oximeter for you to know if you are severely sick, go to the hospital because you need mechanical ventilation. And maybe the chronic landscape is gonna be the post-COVID syndrome, as said. The virus is not there, but maybe some of the components of the virus that are present in different tissues activate the immune system to keep it working and to make you feel like bad, like inflammation, like pains. As I said, this is going to be a big debt for public health in the next months. Which are the groups of risk? Not everyone tend to get severely infected. Not everyone tend to end up in intensive care. It's usually people older than 65, people with overweight, diabetes, hypertension, people chronically sick, bedridden, people with natural or drug immunosuppression, pregnant women, I said obesity with body mass index more than 35, and people with addictions. And we have to keep that in mind because that's important for treatment. This is the only slide I have for you for treatment, but it will take me a little more time. Because early, if there are no risk factors as the ones I told you, all you need to check is oxygenation. Just check the oxygenation, it's okay. And provide some symptomatic treatment. And that's it. Not dexamethasone there, not steroids there, not a lot of polypharmacy that we're using in those patients. If there are some risk factors, maybe monoclonals, the monoclonals that are effective for these Omicron variants and subvariants are this Evushil, I think this is AstraZeneca, and bebtelovimab, I think this is Lilly. And when we are learning to pronounce these weird names of monoclonals, they tell us that they are not effective anymore for the new variant. So we'll have to change and keep changing our minds regarding monoclonals. We do not have in Mexico any monoclonals. We don't even have antiviral drugs. But this nirmatrelvir, ritonavir, this is like the Tamiflu of COVID-19. This is a drug it's Paxlovid from Pfizer. It's very good. There are also remdesivir. This is parenteral, and molnupiravir. I think that the best option now is the Paxlovid. But in those cases, you have to go soon. The sooner, the better. When the patient is in good shape, not when the patient is in bad shape. When the patient is in bad shape, that's usually second week or more. When the oxygenation drops, when the respiratory rate goes beyond 30, then in those cases, you need oxygen, dexamethasone, changing positions, maybe going for mechanical ventilation, or maybe some kind of ventilation, non-invasive ventilation, maybe some anticoagulants. Those are considerations that clinicians have to do patient by patient. By then, I mean, by the second or third week, antiviral drugs maybe are of no use, as it happens with monoclonals. And if things are not going well, we may use some other drugs like tocilizumab, which is an inhibitor of interleukin-6, baricitinib, extracorporeal membrane oxygenation. That's what we have learned from treatment now. And I think that if we follow these simple, quote unquote, simple indications, we will not have such a big mortality as we are having in many hospitals in many countries. What happened also with vaccines is a pity. Vaccines do not save lives. Vaccinations save lives. We know that a lot of people did not have access to vaccinations, and many who had access to vaccines chose not to use them. This is going to be remembered as one of the big advances of medicine. In less than 1 year, we had a lot of different vaccines. As I said, they are not good for you not to get infected. They are very good for you not to get severely sick or to die. We have messenger RNA, we have viral vectors, we have proteins, we have inactivated vaccines. They are good for you not to get severely sick. And this fall of antibodies is not necessarily a proxy of you losing your immunity, because that's something that we consider at the beginning, that as antibodies, tend to disappear, then immunity tend to disappear. No, immunity is much more than that. Let's remember, we have also memory immunity, we have cell immunity, we have an interplay of immunity that goes much beyond than only antibodies. At the beginning, we thought that we will eventually get the herd immunity, the level of immunity where the pandemic will stop because a lot of people will eventually get immunity. We now know that we will never get that immunity. We will never reach herd immunity. It's going to be like Achilles and tortoise, that we think that we are closer and closer and closer, but when we get closer, the tortoise walks a little and little. When the virus left Wuhan, the transmissibility, the R0, was 2 or 3. The Alpha variant had already about 5. I mean, one person was able to infect 4 or 5 more. Delta variants, the Delta variant have a R0 of about 5 to 8. And these Omicron variants have more than 10, 15. It's been calculated even as the most infection virus that the humanity has known. So we will never get herd immunity. Not through infection, not through natural infection, not through vaccination. What we will get is this immunological wall, that through people that has been infected, people that have been vaccinated, and I think that in countries like Mexico, that we do not have vaccinated youngsters and children. We had to do it because we had to build this immunological wall to avoid the virus to go back and infect rapidly and to affect our hospitals and institutions. We need a virus that transmits little by little, drop by drops. And we have to learn the lessons. Hopefully for the next pandemic, the world is investing more and better in health. In many countries, like in Mexico, it was clear that the health system was neglected. Hospitals were in very bad shape. We didn't have enough intensive care units, and the ones that we had were in very bad shape. We didn't have enough molecular diagnostics. We didn't do enough testing to isolate patients at the beginning of the pandemic or at the beginning of outbreaks. We didn't have a good primary care, and patients were over treated with different drugs that didn't help. But in some cases, the early use of steroids made a damage for patients, and that could cause death and disease and death. We need a better primary care. We need more and better intensive care units and surge capacities for mechanical ventilation. When all of this started in Mexico, we didn't have maybe 3,000 beds for intensive care. 3,000 for a country of 130 million people. It's not a surprise what it happened to us. Mexico the world needs a better system of health. We need sufficient oxygen supply. The oxygen in many hospitals, we run out of oxygen in hospitals. And then we send patients to buy oxygen with dealers. And they did lines of 8 hours for an oxygen tank that will last eventually 6 hours. And in the future, we need to manufacture vaccines in many more countries. Mexico used to produce vaccines, but then it was easier to go and buy vaccines from other countries. And now we know that was a big mistake. So these are only a few of the lessons that we have to learn. Because if we do not learn the lesson, the next pandemic that we will eventually have will cause us the same or even more pain than this one. Thank you for your attention.
Recommendations from the public health system are still based on thermometers and sanitizing mats and things like that. They're not focusing on the air quality, for example. How can we reach the authorities so they can listen to the scientific evidences that we have now?
Sorry, I could not hear the question because for some reason I was disconnected.
Can you hear me now?
Yeah, I can hear you now.
Okay, so my question is, how can we manage to convince our authorities to listen to the scientific evidence?
It's not going to be easy. I think that what happened not only in Mexico, in many countries, that it was very hard for politicians to understand that the evidence pointed towards the other side. It's not easy. I think that I had talked this with the Academy of National Academy of Medicine, that we had to be much more proactive in organizations and to ask the government to change the way they do the things. But it's not going to be easy. I do not have an answer for that question.
More questions? No?
Yep.
So let's thank Dr. Macias for his talk.
Thank
Thank you, Dr. Macias.
Thank you.